Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss a case of altered sensory. So shall we start? A 25-year-old female, no previous comorbidities, presents to the ER with history of jerky movements of the body followed by altered behavior. On our initial 10-second assessment, patient was conscious but not oriented. Coming to the primary survey, airway was patent, no pooling of secretions, no hoarseness of voice, no stridor, no signs of aspiration at present. Coming to breathing, respiratory rate of 16 per minute, SpO2 97% in room air. Circulation, BP of 110 bar 70 millimeters of mercury, heart rate of 72 beats per minute. All peripheral pulses were palpable. Two large IV bore cannulas were inserted during this point of time. Coming to disability, GCS of E3, V4, M6, pupils bilateral equally reacting to light. Exposure, temperature of 98.2 degree Fahrenheit, GRBS of 130 milligram per deciliter. Coming to adjuncts of primary survey, ABG showing a pH of 7.35, PCO2 of 40 and bicarb of 22, lactate of 7.5, sodium of 122, potassium of 3.8. ECG showing...
What is your impression on that ABG values and electrolyte values?
Sir, lactate was elevated on the higher side, 7.5.
Lactic acidosis.
No acidosis as such. pH
7.35 is low.
It is acidosis, so that's a little compensated. pH is 7.35 with the PCO2 of 40.
40. Okay, so lactic acidosis may be slightly compensated. Okay, acute compensation might have occurred. What else is there? Sodium?
122, potassium of 3.8.
Okay. So EBG values are not always correct electrolyte values, but we have to consider that. Okay. Lactic acidosis. What is the importance of lactate in seizure?
So lactate levels are elevated in case of seizures.
Normally it is elevated. What is the importance of acidosis in seizure?
So basically, acidosis itself can trigger seizures.
Okay.
But lactic acidosis, when a patient is having seizures because of the widespread muscle contraction, tonic-clonic movements, there will be tissue hypoxia, which is why lactate gets produced.
Okay, any seizure lactate can be elevated. Most of the ETCS lactate can be elevated. In a young child coming with seizure and pH is low, no other reason for acidosis. What else you suspect? Mostly metabolic disorders. Many metabolic disorders, they can have unexplained acidosis. Okay, so metabolic disorders has to be considered when there is a young seizure patient. Okay.
Coming to ECG, normal sinus rhythm, CBC of 5000, CRP 7.5. CT brain was taken and shown.
What are the indications of CT in a patient with seizure? All patients coming in ER with status epileptics, will you do seizure? When will you assess?
First episode of seizure.
Most important is first episode of seizure, especially in an adult patient. Then
following trauma.
Or trauma patient who is developing seizure, we have to take. Anyway, we have to take CT. But in a patient who is having seizure alone, where all you get CT. One is first episode of seizure. You have to do a CT scan and rule out bleed. And some patients may require MRI to rule out a tumor. Okay. Other than that,
any recurrent episodes of seizures with but if the patient has a different somatic
change of pattern, changing the pattern of the seizure, we have to take imaging and CT or MRI imaging and see what is happening. Third one, focal seizures. Focal seizures is one of the important cause. Important cause for focal seizure is tumor. Okay, there also you have to take CT. These are the basic things we should know, because many patients come to ER with seizure. They are not supposed to take CT in all these patients, CT or MRI. Okay, so we have to be very careful. Only selected patients you should image the patient.
MRI brain with contrast and 1 hour EEG was planned.
Contrast is given for what? What you are thinking when you are giving a contrast, MRI contrast in a seizure case?
Infections.
Meningitis. That case you do it. Or
meningitis, will it cause seizure?
Meningitis, if it's like
meningitis is the infection of
meningoencephalitis.
Okay, if we are suspecting encephalitis, you can get seizure. But when you are tumor is the most important thing, you are asking for a contrast MRI. Okay. So everything we should know why we are doing it. Okay.
Coming to sample history, a 25-year-old female, no previous comorbidities, came to the ER with altered behavior. The patient was having his food in the chair, suddenly fell down to the floor with clonic movements of the body, one episode of and lasting for about 2 to 3 minutes. Uprolling of eyes were present, tongue bite were present, frothing from the mouth present. On arrival, the patient was in post-ictal confusion. Ictal speech was present.
Okay.
No history of any thrusting axial movements. The patient was not able to recollect the episodes. No history of any involuntary micturition.
Okay.
No history of any aura, automatisms, ictal vocalization, aphasia, or post-ictal vomiting.
Okay.
No allergic history, no drug history, no history of similar episodes in the past. Last meal was taken at 7:30 p.m.
Okay.
Coming to general examination,
What is the recovery position? What position you keep this patient?
left lateral position.
Why left lateral
Prevent
position?
aspiration.
Aspiration. So most of the patient who recovers from seizure immediately, you have to keep left lateral position to prevent aspiration. Okay.
Coming to general examination,
Theoretically, it is not all correct that you don't develop on the right side. You can, if you want, you can keep in the right side also. But most of the guidelines say you keep the patient on left lateral position, because what is the difference between right lateral and left lateral?
Bronchus will be more
More straight, more straight. Left lateral is slightly on acute angle, is that, so that we are keeping that side, we can prevent aspirations.
coming to general examination, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or pedal edema. Systemic
So in
examination.
a general examination in a seizure patient, what is more important than telling just pulse BP? Pulse is very important because raised ICP can get bradycardia. BP is also very important. Right? Other than this lymphadenopathy, all these things, what is very, very important in a seizure patient?
Is there any rashes present?
One is rash, meningitis with rash. Okay, then. Sensory is already general physical examination. That is neurological examination. Neurocutaneous markers, that is very important. Neurocutaneous markers we are not going to discuss now, but in a patient who is having some skin lesions, neurofibromas, all these things, if it is there, you have to mention, especially when you are getting a young patient who is having seizures. Okay, they are not very common, but if it is there, we have to rule out that. You have to find out that. Okay.
Coming to systemic examination, patient was conscious but not oriented. GCS E3, V4, M6, pupil bilaterally equally reacting to light.
What is the importance of people in the case of seizure?
CVA or is suspecting any
Young female coming who is a college student coming with seizure. Pupils are pinpoint, dilated.
drugs, any
Drugs.
toxin.
Toxicologically, it is very important. Like she told, asymmetrical people also indicates some raised ICP, third nerve palsy, all these things. But drugs, we have to be very careful. Dilated people can be there, constricted people can be there, depending on the drugs they are taking. Okay, drug abuse.
Power 5/5 present on all the four limbs. Other systemic examination was within normal limits.
Okay.
Our initial impression was it's the first episode of unprovoked seizure.
Okay. So, did you take the drug history in this patient?
Yes.
What all drugs can produce seizure?
Common
practice, common clinical practice.
tricyclic antidepressants.
Okay, she is a suppose she is a depressive patient, the tricyclic antidepressant. Like,
Quinolones.
tramadol is another drug, and fluoroquinolones. Common practice, fluoroquinolone is one of the most important cause for seizure. Okay. So, general examination, nothing. So how do you manage this case in ER? So what is your impression? 25-year-old female patient suddenly developed seizure and came to the emergency room. She is not having any other finding, no neck stiffness, nothing is there. Only altered behavior, post-ictal confusion. What first investigation you do, and what are the differential diagnoses?
First, you'll have to differentiate between seizures and pseudo seizures. It's a young
What is the
female.
first investigation you do in this patient?
So apart from
No,
VBG,
no. That hand thing. Like you will lift the hand up and see if it
GR
causes
base.
a
You have to look for a
GR base.
sugar. That is the most important thing. We always
Just sugar.
try to forget. eh? Always remember that first investigation in any patient who is having seizure, altered behavior, loss of consciousness, GRBS has to be checked. Why GRBS?
hyperglycemic and
Both hypoglycemia and hyperglycemia can produce seizure, and seizure will produce
Again hyperglycemia.
hypoglycemia. So we have to check first as a first blood sugar. Then only we should proceed. Suppose there is hypoglycemia, patient will deteriorate fast. If you find out that hypoglycemia, you give sugar, everything will be normal. Okay, spontaneous hypoglycemia, especially female patients. Okay, continue. So do a sugar, then you should have differential diagnosis. What are the differential diagnosis? A young patient coming with seizure.
This can be because of various reasons.
Mhm.
Pain can provoke seizures.
Pain.
Basically, provoked and unprovoked seizures.
Mhm.
Provoked seizures can be pain, it can be anxiety,
Mhm.
or it can
If
be.
patient is already having seizure potential, all these things what you told is correct. Pain, anxiety, deprivation of sleep, menstrual cycle, everything can produce seizure. But in this patient never had seizure, first time she is coming. So what all things you can suspect here? A female 25-year-old female patient come.
Autoimmune.
Okay.
Autoimmune.
Normally infections are very important, but here we don't have fever. The patient does not have neck signal. Mostly infections are ruled out. Then immune-mediated seizures. Okay, why immune-mediated seizures? What are the
Again,
reasons?
young patient and a female patient both are more prone towards autoimmune.
Okay, SLE or vasculitis, primary
For
CNS
5 years.
vasculitis can be there, or tumor, brain tumors can produce seizures. Drugs, like many drugs, recreational drugs like amphetamine, cocaine, all these things can produce seizures. Tramadol withdrawal can produce seizures. Somebody is taking tramadol every day. Suddenly, if they withdraw it, that also will produce seizures.
Metabolic.
So this patient is already having low sodium. We don't know what is the reason for that. Sometimes it can get corrected when you are sending a lab investigation, but that is also can produce seizure. Okay. So these are the common causes. Now you have to investigate. Another important cause is multiple sclerosis. Multiple sclerosis, that can be a first episode. There also you can get seizure. Okay. Continue.
On follow-up, EEG was done, which showed epileptic.
Follow-up is different. Now you have to manage the case. A patient coming to ER with seizure or immediately after seizure coming to ER, you have to manage the case. You should prevent further episode of seizure. So you have to control all these things. EEG can be done during the same period itself. You can do EEG in ER. How do you manage seizure patient or immediate seizure in ER?
Initially, we will put 2 large bore IV cannulas. And if there is active seizure, we will go with to 1 cannula. We will go with benzodiazepines.
What benzodiazepine?
Injection midazolam 0.1 mg per kg.
Which one?
Midazolam.
Midazolam. Okay, midazolam can be given through IV. If IV line is not available,
IM can be given.
IM can be given. If it is a child,
diazepam per rectal can be given on nasal spray.
Or
Nasal spray.
midazolam nasal spray is available. That can be given. So you give brain sedatives like diazepam, lorazepam, midazolam, whatever it is. Then next thing.
Basically, there's a guidelines for it. A patient, the management doesn't differ from any other case. We go with airway, breathing, circulation itself. Wherein airway, we look for any, especially the patient has a tongue bite or anything, aspiration of that is very common. So we first, initial management is to place the patient on a left lateral or recumbent position while the patient is seizing, and place an oxygen mask with a high flow oxygen. Because seizing patient going into hypoxic related neurological complications is too high. So we place the patient on oxygen, left lateral position, and if possible, a basic airway like an NPA is preferred. Because patient would be in semi-conscious state. And then after placing oxygen, this is how airway and breathing will be tackled. Circulation wise, we will put the cannulas on, and then once the IV access is gained, then we'll have midazolam. First, two doses of benzodiazepines can be given.
Okay.
Either if IV access is gained, then we go with midazolam as 0.5 milligram per 0.05 to 0.1 milligram per kg pediatric dosage, and then after that, after 5 to 10 minutes, we reassess. If the patient again has seizures, we repeat the dose.
Okay.
This time with lorazepam preferably. After 10 minutes, if the patient's
What is the difference between midazolam, lorazepam, and diazepam?
basically acting, the duration of
Duration.
onset.
Diazepam is a very long acting drug, so we try to avoid these drugs. We go for midazolam is a very short acting. Lorazepam is a little longer acting. Diazepam is very long acting.
If 10 minutes have passed and the patient continues to have seizures, then we give an anti-epileptic drug like a phenytoin, 20 milligram per kg. If the patient is already on phenytoin, then we give phenobarbital.
How do you give
That is
phenytoin?
again
What is the
20
dose of
milligram,
phenytoin?
20 milligram per
How do you
kg.
dilute?
Normal saline.
Normal saline. How do you give? How fast you give? So 20 milligram per kg body weight will be around 1.4 gram in a 70 kg patient. How do you give it? How fast you give? For 45 minutes. You have to give over 45 minutes. Whereas other one,
Phenobarbital is
phosphonatoin.
That is a
15 to 30 minutes you can give little faster. What else advantage of phosphonatoin?
Water soluble. IM can.
IM can be given. Other one is it can be given IM. It can be given diluted in dextrosaline. Okay, if the patient is already having hypoglycemia, that will be a very good choice. So phenytoin or phosphonatoin, both are equally effective. Other one is prodrug, so it will act faster than other drug. Okay, then phenobarbital dose,
that is also 20 milligram.
same dose. Okay.
So after 20 minutes, if the patient continues to seize, that's when we declare this patient as a status epilepticus. And
Okay,
then
what are the
next
alternatives?
management states
Alternatives for phenytoin? Is there any alternative as a first line? Levetiracetam. What is the advantage?
Again, it won't have the side effects that phenytoin has. Phenytoin has phenytoin itself can one trigger seizures, and apart from that, it has hyper sensitivity reaction. Such as hyperplasia.
Where it is most useful, which condition it is?
LFT.
LFT. If the patient is like we get many patients with chronic liver disease and all, there it is mostly very useful comparing to other drug, and action is almost same. Now it is the first line drug in many guidelines instead of phenytoin. Okay, then phenobarbital is a second line drug. Third line drug is intubate and mechanically ventilate.
After 20 minutes, we intubate the patient.
If you don't intubate, what will happen?
Neurological complication because of long sustaining hypoxia.
Okay.
Patient can have hypoxic ischemic injury, encephalopathy.
Okay. If the patient does not improve with your phenytoin, if she deteriorates with phenytoin, young female patient, what will you suspect? Urine is red in color.
Porphyrias.
Which porphyry?
Acute
Intermittent
porphyrias.
What is the drug of choice there? Diazepam or lorazepam, midazolam with dextrose. There is a slight difference, but even there also you can use levetiracetam. Okay, so levetiracetam is nowadays it is the first line drug in seizure. After your sedative, brain sedative, there is a maybe second line. First line is diazepam or lorazepam or midazolam. Then go for levetiracetam. That has got lot of advantages. What are the other advantages? Drug interactions. There are many drugs has got interaction with phenytoin. So levetiracetam has got lesser drug interaction. Okay. For porphyria we can give, and it can be given in liver disease. So many advantages are there. Okay. And what happened to the patient?
So toxicology screening, autoimmune screening, everything was done. Found to be negative.
Okay. You want to do an LP for this patient?
Yes.
Why you want to do LP?
Raised ICP can be checked. The opening pressure.
ICP you are checking MRI now. So MRI is done, CT is done, nothing is there.
For multiple sclerosis, albumin, that dissociation.
Okay, so albumin can be elevated in most of this type of conditions. You can do, but what happened to the sodium? So LP has to be done. I don't know what happened to LP. EEG has to be done. EEG shows what?
Shows epileptiform pattern.
Okay, focal or generalized?
Generalized.
Okay. Sodium, what happened?
Sodium, lab sodium came out to be normal.
Normal. Okay, only in ABG it was
Sure.
abnormal. So how do you manage this case afterwards? So you are admitted this case with your first line drugs. How do you change to IV drugs? Oh, sorry, oral drugs. So you have started 20 milligram per kg body weight phenytoin. If the patient is seizure is controlled with that, she will be in your ICU. How do you give phenytoin? What is the dose of phenytoin?
20 milligram.
There is a loading dose. Loading dose is different. Then 100 milligram TID. That is a dose. 100 milligram TID or 200 milligram TID you can give. But normal dose is 100 milligram TID. Then make it tablet. 100 milligram tablets are available. 100 milligram tablets TID. Then as the seizure is coming down, you can reduce the dose. Like first initially we are giving 1 TID, then maybe 1 BD, then you may give 1 OD. How long you have to continue? It is not like our problem, emergency medicine problem, but how long? Okay.
2 years.
Normally, unprovoked seizure, it may like we usually we continue the treatment for 6 months, and we have to. Meanwhile, we have to investigate everything. If everything is normal, even then you can try to stop after 6 months. But normally, some patient may require 2 to 5 years. Okay, then only evaluate. Okay. What other problems she had in the ICU? Any other problem?
Stable, uneventful.
Conscious.
Regain consciousness.
Okay, no other seizures. Could not find out the reason
Yes,
also.
sir.
Toxicological screen is negative. Okay. CNS vasculitis sometimes will not be able to pick up in the MRI or CT. Okay, that is the only issue. Young female coming with seizure, SLE has to be ruled out. DSDNA was done.
Yes.
Okay, so ideally we have to do that. LP has to be done, and we have to rule out vasculitis, CNS vasculitis, because no other reasons are there. That's why. Okay, anything else? Okay, thank you.